and I'm going to talk about a very light topic, which is effective communication for when you do procedures out of the office. Effective communication is nothing more than good documentation. And as Medicare indicated in 1995 in their E&M coding manual, if you didn't document it, it's simply assumed that you didn't do the work. So when you have effective documentation, you're not missing any charges. And you know, you're not getting paid too much in the OR. And also, when I looked at my total billings, OR is but a very small amount of my total revenue. So you want to effectively document so that you can make the money that you deserve using the least amount of effort. And I'm as lazy as anybody else, so I want to do it as efficiently as possible. Some of the reasons why documentation is important. Number one, you want to demonstrate medical necessity. And we do that through ICD-10 codes, the diagnosis codes that we use when we perform a procedure out of the office. In addition, you're simply telling the payers and everyone else why you are doing the procedure in the operating room. You're demonstrating what you did with effective and complete documentation. You're showing the details of what you actually did in the operating room so that no one would question you. Lastly, the importance of documentation comes in the form of dollars. It helps if you understand the rules and you document those rules and those things that you did in the operating room, understand the special circumstances and nuances, and you convey those nuances to your coders, you end up getting what you deserve with the least amount of effort. But that requires that you do the documentation, and just as importantly, you have to understand why you're documenting to play the game. So you need to know the rules of the game in order to play this game effectively. Here's the punchline. Efficient out-of-office service billing requires that you understand both the coding and the billing rules and their application. It's not enough to just understand the rules and know the rules. You have to know how to use them. Mark has already gone through global payments. Basically, payment for the primary procedure includes the payment for everything pre-op, whatever you did during the surgery, and also the post-operative care. There's also something that we mentioned multiple times, bundling, or the bundling rules. This is basically for payers to not pay you for every single component of a surgery a la carte. If you do things together, most of the time, they're going to bundle everything together so that they pay you one bill and not pay you for each individual component. We've already talked about the importance of documentation when it comes to medical necessity and proof of service. Also, for those of you who participate in value-based payment systems, it's important for you to have good, complete documentation so that you can demonstrate the money saved and also so that you can get your bonuses. Patients more frequently than not have free access to their medical records. Complete and clear documentation is also important in that regard. Payers, all of you coders and billers know they're constantly asking for documentation and stuff that we've done. So complete documentation, complete and efficient documentation by your surgeons, providers is imperative. And lastly, medical legally it is imperative that you do a great job with documentation. I would tell you anecdotally, last couple of cases that were brought on against me were dismissed with prejudice, meaning there's nothing else that can be done. So basically they dismissed the cases and I didn't have to go to trial. I didn't have to go through arbitration or settlement. Solely, and this is what my attorney told me, your documentation really, really helped you in these cases. So take it for what it's worth. Complete documentation is also important when it comes to explaining the special circumstances and nuances that we've discussed earlier today. For instance, if you did multiple procedures, you did separate procedure in a different lesion or structure, modifier 59 for the private payers and XS, X-ray Sierra, for the Medicare payer. And also separate encounter. Mark mentioned this already earlier this afternoon. If you are doing things through a separate incision, modifier 59. If it's a different procedure, unusual overlapping services, XU or modifier 59 for private payers. Bilateral, we've pounded that one to death. RT, LT, vasectomy, that we just talked about this afternoon. Documentation helps in demonstrating the nuances. And when it comes to bladder cancer resection, TURBT, you've got 3 sizes. And of course, Mark has already mentioned, you count the largest lesion when you're picking CPT. So when you have a large, greater than 5 centimeter lesion, you will use the appropriate CPT code. But how would you know it's a coder? You don't, unless the surgeon tells you that the largest tumor is greater than 5 centimeters, or he or she tells you that he or she resected a tumor greater than 5 centimeters. What about bladder stones? Bladder stones, even though in the CPT description, it talks about less than 2.5 centimeters or greater than 2.5 centimeters, in this situation, you can aggregate the total volume or the size of the stone, which is different than bladder tumor. So again, you have to understand the rules to be able to document that, to share this information with your coders so that you can be appropriately paid. We've already covered complex or modifier 22 when it comes to bladder tumors. If you have a multifocal tumor with the largest one being greater than 5 centimeters, I actually did a video of that in the Thriving Urology Practice Facebook group, and where I showed you how big and extensive the tumors were, and I was able to resect everything. So the largest tumor was greater than 5 centimeters, but I did so much extra work, I was more than justified in documenting and using modifier 22. And it's interesting, when I went out to the reception area after the surgery, I said, boy, that was more than an extensive resection that I did on your husband. And the lady said, well, that's why they pay you the big dollars. And my response was, they don't pay me enough to do this. Modifier 22, despite the fact that you are getting paid a little bit more for the amount of work that was done, really, from a financial perspective, it is not worth it. Definitely worth it for the patient. I was able to, believe it or not, cure him of his bladder cancer. He hasn't had any recurrences, but from a purely financial perspective and the amount of work that's required, definitely not worth it. So in that situation, a complex modifier will be indicated when you're dealing with a large tumor like that. So if you have an extended or complex surgery, you definitely want to document that so that your coders can use the code, and the surgeon is explaining the nuances by explaining and documenting why a 22 modifier is indicated. If you have to take the patient back to the OR, like the TURBT and then the bleeding, and you have to take the patient back to the OR, we just talked about that. And also if you have a stage procedure, for instance, stent removal, that you know is going to happen later on, you want to use a stage procedure. And I have a shortcut for you later on. I'm going to show you how you can help the doctors remember to use the stage modifier. TURP actually has 2 different codes. If you're the first person who did the TURP, or let's just say, for instance, you inherit this patient who's from out of town who had a TURP 20 years ago, and now the patient has prostate regrowth. Did you know, not the coders and billers, I know you know that, but for the physicians in the audience, did you know that there's a different code that you would use for regrowth of the prostate tissue after an initial TURP? So number 1, history is important to get from the patient or family. Number 2, when you do that TURP due to regrowth, you want to let the coders know that this is due to regrowth, because if you try to bill Medicare for 2 TURP codes, you're going to be denied that second time until you bill it with the right code. Again, appropriate communication with your coder is going to save you time so that your revenue cycle is much quicker. And lastly, MUE, or medically unlikely edits. For that one particular day of service, Medicare, the payers are going to say, here is the maximum number of units that we're going to pay for this particular procedure. Great example will be UroLift. 7 is the MUE for UroLift for that one day. But I not uncommonly put in 8 implants. And you know these implants are $900 or $1,000 each. So how do I get paid for that 8th implant? Well, by clearly documenting the medical necessity of using that additional implant for that particular patient. And it comes down to documentation in the chart to justify why that 8th implant is needed. I've said this multiple times in writing, in my videos, that, and this is going to piss some people off, the OR, despite the fact that we fight to be in the OR in residency, In real life, OR is nothing but an expensive hobby. When you are thinking about opportunity costs, when you are thinking about the efficiency in which you can generate RVUs in the office versus in the operating room, how much less control you have in the operating room, and everything surrounding the OR is really nothing but an expensive hobby. So if you want to spend time there, if you enjoy spending time there, making sure that you are efficient with your documentation so you are paid appropriately and quickly is key. When you are doing surgeries, don't reinvent the wheel every single time you do surgery. Take some shortcuts, and we're going to go over that real quick. Who, what, where, when, and why when it comes to surgeries. You want to clearly document on whom you're performing the procedure, any surgeons, any assistant surgeons or co-surgeons, what means exactly what procedure you did, where you did the procedure, place of service, as mentioned in the chat earlier. Somebody asked about place of service. It was at the surgery center or the hospital. It's important to document that. Any global issues that you need to convey to your coders and billers, which could pull your procedure out of a global of another procedure so that you don't get denied payment for the procedure that you're doing that day, and why you're doing the procedure. Accurate ICD-10s will be important to demonstrate why you're doing the procedure and the medical necessity for the procedure. So the question comes to why or how. What is the best way for the surgeons to communicate what he or she did in the surgery center and in the hospital with the coding and billing staff? Well, there's several ways. You can think about, well, the surgeon can grab a demographic sheet and simply chicken scratch what he did on that date, or you can use a note card or some sort of a paper napkin and write chicken scratch on it, or you can simply do the procedure as the surgeon, dictate that in the op note, and then ask your clinical staff to get that information from the hospital and abstract what you did in the ICD-10 diagnoses regarding that particular procedure. That's a lot of work for the coding staff. Some sort of electronic method. Maybe the doctor, the surgeon can connect to the office, or the office staff can query the hospital systems and obtain the medical records. Maybe the surgeon is using a compliant, secure method via voice to share the information about what was done to what patient, when, with the coding staff. Or maybe telepathy, ESP, extrasensory perception, or maybe some other method that I haven't covered. You have to pick the one that works for you. Some of the best practices that we'll cover: short list of ICD-10 diagnosis codes paired with the surgeries that are most commonly done by the doctor. Doctor would typically document all the services that were done with the primary diagnosis and tell the staff that this is either regrowth or maybe this is done under the global of another procedure, and the doctor will say this is a staged procedure to kind of hint to the coding staff that a specific modifier may be needed. You want to communicate that either electronically or by paper, and importantly, the surgeon should contemporaneously document this encounter on the day of the surgery. When it comes to developing a short list, it is pretty easy to come up with the ICD-10s paired with the surgeries that are typically performed. When you do this in the hospital as a surgeon, typically it may be a scheduled surgery, and this is typically an inpatient or an ER case. In the surgery center, these are typically scheduled cases from the office, and in the office, clearly these are scheduled cases. So developing a short list, pairing the ICD-10 with the procedure codes is fairly straightforward. The urologist, surgeon, the coder, and the billers should work together to come up with the appropriate co-pairs. When it comes to sharing that information, you want to figure out, do you want to use paper or electronic? And here's an example of what I use when I do a ureteroscopic procedure. So this is a paper format. I write the date and the time. I'm so lazy, I don't even want to write right or left. I simply check right or check left. Is it ureteral stone or renal stone? Another check, another check. Is flank pain involved? I would check that. And when it comes to procedures, even if the doctor, the surgeon doesn't remember all the bundling edits that are involved, by creating this type of a list, you can just have the doctor check what was done. And you are reminding the doctor, if you look across ureteroscopy, laser lithotripsy, and stent, you're looking at a modifier 59. Is it a separate or distinct service? Is it a complex procedure? Is it a stage procedure? So this kind of clues in the surgeon, hey, do I need to be thinking about these? Of course, that means the surgeon understands what is a modifier 59 or X event, or what is a complex procedure and what is a stage procedure. So understanding the rules and applying the rules becomes imperative for the surgeon. And here's a little tip right down here. If you look at cystoscopy, cystoscopy, ureteral catheterization with stone manipulation without removal. This is a code that actually pays relatively better than the other codes. So the way I would use that code is, if I know the stone is at the UPJ or proximal ureter, and I'm simply going to put up a stent, in my pre-op discussion, I would say, I will plan to possibly manipulate the stone when possible back into the kidney to unobstructed, and then put up a stent. And then that way I can justify billing for that code. And then when it comes to ureteral catheterization, ureteral stent placement, it's just another check. And I'm, of course, the surgeon, so I don't even write my name. I don't even have to do a drop down list. That is just me, surgeon. When it comes to shockwave lithotripsy, again, date and a time, I'm checking right stone, left stone, ureter, kidney. I am documenting, is it a right or left shockwave lithotripsy? Is it a stage procedure? Again, just another check mark. And typically it's just check straight down the left side. When you go down to the bottom section, I will document how many shocks, what type of machine, what type of shock source. Very important at the very, very bottom, and let me enlarge this image here. At the very bottom, lower right-hand corner, the last two lines reminds the surgeon, will additional treatment be needed to achieve full clearance for this procedure, for this stone? And if it is, perhaps a modifier 58, a stage modifier, may be appropriate. If the surgeon had previously placed a stent and then on a separate date performs a shockwave lithotripsy, what is going to be done with the stent, right? So if the surgeon can be reminded that, hey, I plan to remove the stent once the stone is cleared, check that box, dictate that in an op note. So when the time comes for stent removal in the office, you can use the modifier and pull that stent removal out of the global of shockwave lithotripsy so that you can be paid appropriately for that stent removal. And this is how I do it if I were to take an ER patient or inpatient to the operating room. Obviously, I'm dictating an HMP, so I can give the coding staff what is the pre-op diagnosis and the plan. And right after surgery in the recovery room, in the immediate, in the PACU or post-anesthesia care unit in the recovery room, I write down the immediate post-op note that you saw. I give more clues regarding the diagnosis and the procedures performed, because the pre-op diagnosis may not completely match the post-op diagnosis all the time. So it's important for me to do that so that the coding staff can appropriately code with the right ICD-10 so that the procedure can be paid efficiently. I then fax both the face sheet from the hospital and the immediate post-op note to the office from the PACU. It is secure. It is HIPAA compliant. I don't have to carry a piece of paper. I'm not going to lose that piece of paper, as I've seen in the doctor's lounge and in the locker room where these demographic notes with the chicken scratch written on it. Thankfully not often, but I sometimes find them in those areas. So that is the way I do it. And if it's an existing patient who was seen in the ER and I did a procedure, I will log into my office via virtual private network from the PACU and then document the past surgical history, what I did, the ICD-10, the pre-op diagnosis and post-op diagnosis, and then any electronic prescriptions I will send out through my EHR via VPN. And then I will also document in my EHR the planned follow-up for the patient. So when the patient or family calls for follow-up, they can easily look in the EHR and tell whoever's calling what are the next steps. And then I go home. So here's an example of what it looks like. The top screenshot is the past surgical history. So for instance, if the patient came in with an obstructing stone, I will document in my EHR that I put in a stent on that particular date and the laterality of the stent placement. And then in assessment and plan, on the bottom screen, the diagnosis was ureteral stone, the prescriptions that I sent to the pharmacy, and then the plan is to follow up in 1 to 2 weeks and to dilate, to let the ureter passively dilate so that we can come up with a game plan, whether that is ureteroscopy or shockwave lithotripsy. We can easily determine that at that time. If the patient goes to the OR from the office, obviously there's an HMP that's already in the EHR in the office containing the ICD-10 and the CPTs. The scheduler, and I'm going to show you in a second, uses a short list on a booking sheet to schedule the surgery. And if you have an electronic booking system with a hospital or a surgery center, obviously copying and pasting the information will be more efficient. I then, after surgery, same thing, write down and document the immediate post-op note and convey the nuances to the biller and coder. Again, faxing that information securely to the office, document in the office electronic health records, like I did like I did with the ER patient and the inpatient, and then I go home. This is an electronic booking sheet that we use. So all the areas with the carets, the P name, the PSSN, the PPOB, the PSEX, those are all electronically, automatically filled in. If I'm scheduling this patient for resection of a bladder tumor, pre-op diagnosis with bladder mass, and in my EHR, I would document, is it going to be a small, medium, or large tumor? And all my booking staff, scheduling staff needs to do is to check the box. And then usually with immediate postoperative intravesical chemotherapy, so that box is checked. Everything else is semi-automatically filled out to help you guys schedule surgeries. This is what my surgery schedule looked like 2 days ago. I did several shockwave lithotripsies, and believe it or not, that ureteroscopy is especially meaningful to me because it was my first ureteroscopy since my stroke about 2 months ago. So I did a ureteroscopy, took care of a stone, and I, believe it or not, that was a modifier 22 event, and I put up a stent. The reason why this op report is op note or the OR schedule is important is because twofold. Number one, the coding staff can go against this list and say, oh, Dr. Lin did 6 surgeries or 7 surgeries. We need to make sure there's follow-up for those patients. And for this particular ureteroscopic case, there's a stent involved. So my staff will need to make sure that this patient actually follows up and make sure that we don't have a retained stent with all the potential complications involved with the retained stent. So having this list and making sure somebody's actually going after this list and checking the op note, the bill with the surgery list is imperative. Here's a bonus slide on in-office procedures. I mentioned this briefly earlier. When the patient is scheduled for a procedure, let's just say UroLift, the patient comes in and then I see the patient, I tell the staff, actually I electronically document in the EHR, I don't even talk to the staff. I document in the EHR that I'm going to do a UroLift on this patient. I document how many implants that I plan to use. The checkout staff will document in the practice management software on the day that I do the UroLift system, the procedure, the name of the patient, the date, the time, and also how many implants. So that is already documented in the practice management system. On the day of the procedure, my medical assistant starts the encounter. She literally brings in the pre-op diagnosis of BPH with obstruction, the code for UroLift 52441, and then the prescriptions that I usually prescribe, which is antibiotic and Peridium. And then when is the follow-up? So if the patient has preoperative urinary retention, the follow-up will be for a PVR. If the patient has no preoperative urinary retention, the follow-up will be typically 6 weeks. All that is done by somebody else. So we don't miss any charges for the UroLift. And I will also document in the chart how many implants that I actually placed, because sometimes I put in more, sometimes I put in less. So I literally cannot do the procedure without documenting the encounter. I can't sign off on a chart without looking at the assessment plan and documenting the procedure. I use extensive auto replace text and dot phrases. For instance, if I am doing a standard vasectomy, on the screen where I do the documentation, I literally verbally say sig vas nitrous. It'll automatically populate the date, the preoperative diagnosis, post-op diagnosis, the vasectomy procedure. I'm the surgeon. The fact that I used nitrous oxide, the lidocaine that was used, it'll document all that for me without me lifting a finger. So I use a lot of automation. You should consider doing that. If your EHR supports it, if your voice recognition supports it, definitely do it. Obviously, whenever you do a procedure in the office, you want to do the documentation that same day. Documentation, everybody tells you, yeah, you should do it right away, but here are the actual tips. You want to consider using a scribe for those of you who have access to scribes in person, in real life, or what a lot of practices are using is a virtual scribe. Sometimes it's $10 an hour. You can have English-speaking Philippine residents or Philippine nurses. They're actually nurses for $10 an hour that you can hire who can virtually follow you and do the EHR documentation for you. I personally use voice recognition. I've been using it since 2010. It is extremely fast and I've really customized it. So there are a lot of different voice recognition platforms out there. You want to consider using that. Lastly, you want to be open-minded. Some of the best ideas have come from my front desk staff, my medical assistants. So do not think that your way is the only way. Be open-minded to ideas. Ask for ideas. One of the first things that I do, actually this week I did this. We had a brand new surgical scrub in the hospital. I worked with him for the first time ever. I always tell my scrubs the first time that I'm working with them that you see a lot of other urologists and surgeons do the same thing. If you know of a better way, please let me know, because I'm in my little silo, I'm in my little bubble, and I don't know what is always best. So be open-minded for good ideas that may come from surprising places. Lastly, I will conclude with understanding the coding rules and the how of effective documentation will help you make more money easily and with the revenue that you deserve. And I thank you for the privilege of your time.
Thank you, John. Great, wonderful information. You had a couple questions in the chat. One, Selena wanted to know where she can get forms like yours.
You know what? Well, the slides will be available, right?
Yes.
So, okay, so you can get it from there. And I think I've already uploaded them to the Thriving Urology Practice Facebook group. That's under the files section. So if you want to go there, you can find that there.
All right. And then Mo Ghazi said, John, what EHR are you using?
So the best EHR is the one that works best for you. So don't use my EHR because I use it. It's worked for me, and I've been using it since 2006. Before it's called Allscripts. So I've been using it for a long time. But I use Allscripts Professional EHR, and which is the EHR that United Urology Group, this large private equity-owned group, uses as well.
All right. I think that was it. Yes, I don't see any more questions. Okay. So
let me mention this. Stacy mentioned that our office implemented the use of the immediate post-op note that John created several years ago. They're much better than the note cards that my physicians were previously using. And I think I emailed a copy of the template. Oh, okay. Well, you can find me on social media at JCLINMD, Instagram, Twitter, Snapchat, TikTok. I'm there. And also I'm on YouTube, Facebook. You can find me at JCLINMD, DM me, or you can private message me right here or through Facebook.